Okay, well, it's 5 minutes after 12 o'clock in PNG and 5 minutes after 1 where I am. So we'll make a start, I think. And well, good afternoon, everyone, and welcome to today's pediatric lecture. I wanted to talk today about fluid and electrolyte management in pediatrics. It's a really common problem. It affects most of the children we look after in some way. And it's also something that can go well or badly wrong if it's not managed properly. So I just want to talk about the basics of fluid and electrolyte management, and then mostly some clinical aspects of how we manage fluids and electrolytes in sick children. So this is what we'll talk a bit about today. So I'll just admit some more people as we go. We'll talk about some aspects of fluid and electrolyte physiology that you need to know if you're going to be managing children well. And oops, I'll just admit some more people. So firstly, to understand the different body water compartments in the body, and secondly, to have an understanding of antidiuretic hormone and its effects in the on fluid management, and also the renin-angiotensin system. So if you understand sort of water intake and antidiuretic hormone and the renin-angiotensin system, then I think you've got a good understanding of the physiology of water and electrolyte movement within the body. I want to focus a bit about how to calculate fluid replacement in children with dehydration. And just so as you know how to do that in a child who's 5% or 10% dehydrated. So it's very important that we understand the way in which you can calculate fluid replacement in children with dehydration. It's always an estimate, and you always need to come back and reassess the patient, etc. But if you can understand the calculation, that's important. I'll say something about hyponatraemia, so low serum sodium, something about hypernatraemia, because they both have quite serious consequences for other systems within the body. And if we get time, we'll say something about fluid boluses and shock as another aspect of fluid management. But let's focus a bit first on the physiology and then how to calculate fluid replacement in children who've got dehydration. So as you know, there are two main compartments of the body, broadly speaking. There's the intracellular and the extracellular compartment. And in the extracellular compartment, that is the water that exists outside the cells. There's the intravascular compartment, so all the water within the blood vessels, and the water outside the cells and outside the blood vessels, which is the interstitial compartment. And the main reason to describe these is that these change with age. And but both the total body water in a baby is much greater as a proportion of the total body weight than in an adult. So babies have contain more water, and also most of that extra water is contained within the extracellular fluid. The intracellular fluid remains much the same per kilogram of body weight. So most of the water that's excess in neonates and in children relative to adults is in the extracellular fluid. I'll just admit a few more people as we go. The blood volume is also higher as a relative proportion of body weight in a neonate and in a child than it is in an adult. And what that means is that newborn babies or young children, infants, will be more susceptible to blood loss as a proportion of body weight than adults would be. They also have good mechanisms to compensate for that, but that's another talk. When babies are born, they have a higher total body water than what they will have in a week or two's time. And most of that is extracellular fluid. And most of that is why we see newborn babies lose about up to, but not more than up to 10% of their body weight in the first week or 10 days of life. They're losing that extracellular fluid. Yeah. Okay. When we think about what regulates water movement in the body, you need to understand what the effect of the posterior pituitary. This has a lot of clinical implications, and that's why I wanted to go through it in some detail. The posterior pituitary responds to both changes in blood pressure and in blood volume and in blood osmolarity. And in response to changes in blood pressure or blood volume or blood osmolarity, the posterior pituitary stimulates antidiuretic hormone, and antidiuretic hormone is stimulated in response to low blood pressure. Obviously, if you're hypotensive, the body wants to retain more water, antidiuretic, so it retains more water. Or if your plasma volume is low, then the body wants to retain more water. Or if your osmolarity is high, that is, you've got more concentrated blood, then the body wants to retain more water to normalize the osmolarity. And that's why antidiuretic hormone is secreted. And it's secreted in response to many normal stimuli, such as low blood pressure or low plasma volume or increased osmolarity. But it's also, antidiuretic hormone is also stimulated in a variety of different clinical, I'll just let some more people in a variety of different clinical situations, particularly in meningitis or in pneumonia or bronchiolitis, in children with sepsis, and after an anesthetic or after surgery. There's a variety of different stimuli that will cause the posterior pituitary to put out more antidiuretic hormone, and that can lead to this so-called syndrome of inappropriate ADH secretion, which can lead to hyponatraemia, which we'll talk a bit about later. But just remember the posterior pituitary produces antidiuretic hormone in response to the stimuli of low blood pressure, low plasma volume, and increased osmolarity. And the ADH acts on the collecting ducts. It doesn't act on the nephron, but it acts on the collecting ducts, and that causes water movement back into the interstitial fluid and then reabsorption of that water. So instead of passing a very dilute urine, then if there's a lot of antidiuretic hormone being produced in response to these normal stimuli or inappropriately, then there'll be a more concentrated urine. Okay. Yes, all right. There's a couple of conditions whereby there's reduced antidiuretic hormone stimuli. In fact, there's the posterior pituitary produces no ADH, antidiuretic hormone, and that occurs in the opposite of these situations. So if you've got very high blood pressure, or if you've got very expanded, enlarged plasma volume, or if you've got very low osmolarity, then the posterior pituitary shuts down production of antidiuretic hormone, and that can help correct those abnormalities in the cardiovascular system. It can normalize blood pressure or normalize the plasma volume or normalize the osmolarity. But just I think the main thing to remember is, oops, I'll just admit a couple of people. The main thing to remember is the effect of antidiuretic hormone, what stimulates it, what it actually does at the level of the collecting duct, and in what situations is antidiuretic hormone produced in an inappropriate way, or in a apparently inappropriate way. The second physiological mechanism is the renin-angiotensin system. So I'll just have to let a few people in. Is the renin-angiotensin system, and it's in a similar way. The renin-angiotensin system responds. Renin is produced by the kidneys, and renin responds to the same sorts of things. So low blood pressure and low cardiac output, and renin is converted by a liver enzyme called angiotensinogen to angiotensin 1, and then that's converted by angiotensin converting enzyme to angiotensin 2. And angiotensin 2 is the most potent vasoconstrictor in the body. It causes intense vasoconstriction, and because of that, it reduces urine output, right? And it reduces glomerular filtration rate. And so what you end up with that, as a response to that, is an increase in blood pressure, because you get reduced urine output and increased blood pressure because of angiotensin 2, this intense vasoconstrictor. Angiotensin is also converted into aldosterone, and of course aldosterone leads to sodium reabsorption and increased water retention. So if you remember that ADH just increases water retention at the level of the collecting duct, whereas aldosterone increases sodium retention and water retention. Of course, every time a molecule of sodium is absorbed, then a molecule of water is absorbed, and that increases the blood pressure, but also the vasoconstrictive effects of angiotensin II leads to increased blood pressure. So this is an important cycle. So renin, angiotensin, aldosterone system, and the ADH system. And if you understand just the basics of this, what I've just described, then you'll more or less understand all the things about water and electrolyte physiology within the body. In terms of the amount of water that people need, I think it's important that we have some understanding of the way in which this is calculated. And typically, on a given day, a child somewhere in the first up to 10 kilos will need about 100 mils per kilogram per day of water. If they're more than that, so 10 to 20 kilograms, they'll need that 1,000 mils for the first 10 kilos, plus 50 mils per kilo per day for the next 10 kilos. So if they're, for example, 14 kilos, then they'll need 1,000 mils plus 200 mils. So 4 times 50, right? And if they're more than 20 kilos, then they'll need 1,500 mils. So the amount for a 20 kilo child plus 20 mils per kilo thereafter, right, are beyond 20 kilos. I've put here the amount of water in mils per kilogram per hour, because sometimes we calculate it as mils per kilo per day, and sometimes, perhaps more commonly these days, we're calculating it as mils per kilo per hour. If you want to regulate the amount of water, intravenous fluid a child receives through a drip, then you calculate it as mils per kilo per hour. And then I put here what the, if you could mute yourself, that would be good, eh? Okay, I've put here what the average amount of sodium per day is. So 2 to 4 millimoles per kilogram per day. And as you get larger, then you need proportionately less. It's about 1 to 2 millimoles per kilogram per day. And when you're over 20 kilos, about 0.5 to 1 millimoles per kilogram per day. Similarly for potassium, it's a bit more in the first 10 kilos and a bit less thereafter. Now, glucose, similarly, infants and neonates need some more glucose per kilogram than older children. And so I'll just go through in a little while how to calculate fluid replacement in children with dehydration, and you'll see how this works. So, for example, when we use this rule, the 4-2-1 rule, 4-2-1 rule, or the 150-20 rule, 150-20, let's use the 4-2-1 rule. A 17 kilogram child will need, well, with the 150-20 rule, 100 mils for the first 10 kilos, so that's 1,000 mils, and then 50 mils for the next 7 kilos, so 350 mils. So that's a total of 1,350 mils in 24 hours, or according to the 4-2-1 rule, 56 mils per hour, okay? A 35 kilo boy would need 100 mils per kilo for the first 10 kilos, then 50 mils per kilo for the next 10 kilos, so that's a total of 1,500 mils, and then 20 mils per kilo for the next 15 kilos, because 10 plus 10 plus 15 is 35, and that's 300 mils. So that child will need 1,800 mils over a 24-hour period, or 75 mils an hour. It's really important to understand how to calculate the amount of maintenance fluid a child receives, because you can calculate it as the 150-20 rule or the 4-2-1 rule, and then you can adjust the amount of fluid that you'll give, let's say, depending on the context for that child. So if this 35 kilo boy was unconscious with meningitis, then he'd need less than that probably, unless he was hypovolemic. Unless he was hypovolemic or dehydrated, he would need less than that. But it's a good starting point, the 150-20 rule or the 4-2-1 rule. Right? The 150-20 rule or the 4-2-1 rule has really worked out for children under normal conditions. That is, children that are active and could you please mute your device if Okay, this these rules are really worked out for children under normal conditions. So the children that are active and playing normally, if you're sick, if you've got a serious illness, then you may need more fluid because you're dehydrated, or most likely. Oh, could you please mute your device, please?
Sorry, Trevor. Mbak Wida, tolong bisa di-mute, Mbak. Sorry.
Yeah, thanks. Please mute your device. Okay. Yeah. What I was saying was that the 150-20 rule is really worked out for children under normal circumstances. If you're sick, then your maintenance fluid requirements are going to be, generally speaking, less than that. All right. And if you give that much intravenous fluid to a child who's very sick, then sometimes that can cause fluid overload and cause other problems. All right. Let's talk about rehydration in a child with dehydration. So I hope you can see there this child and the clinical signs of dehydration that the child has. You can see that he looks lethargic, his posture is, he looks hypotonic, his eyes are sunken, he's got what we call a scaphoid abdomen, his skin pinch is slow. You can see all this clinical signs of dehydration in a child who, when you look at his legs, he doesn't look like he's very malnourished. It just looks like you can see he's reasonably well nourished, but he's profoundly dehydrated. And so this child would be 10% or more dehydrated with these clinical features. And you can work out the amounts of, this is what I want you to really understand today, is how to do a calculation for rehydration of a child like this. And we can work it out based on the amount of maintenance a child receives. So we've talked about how we calculate the maintenance, a 4-2-1 rule or the 150-20 rule. We can work out the amount of the deficit, and that's based on the percentage of body weight loss. And that's based on the clinical signs. If you saw a child like this, lethargic, sunken eyes, scaphoid abdomen, slow skin pinch, then you'd know that this child was more than 10% dehydrated. And then we can add some additional fluid for ongoing losses, and I'll explain what that means. 50 mils per diarrheal stool if you're under 2 years, and 100 mils per diarrheal stool if you're over 2 years. I usually ask parents, how many times has the child had diarrhea in the last 6 hours? And then if the child's had 3 bowel actions in the last 6 hours, then you know how much you'll need to add for the next 6 hours, how much extra fluid you should add. Children with such severe dehydration, of course, we need to correct shock first, but then we need to replace the deficit. And typically, I would normally replace the deficit over 24 hours, sometimes over 12 hours, but typically over about 12 to 24 hours. Sometimes people replace the deficit much quicker than that, but there are some people who try to replace the deficit over 4 hours. I think that's probably too quick. If you wait for 24 or 48 hours to replace the deficit, then sometimes you come back after 12 hours and you're still behind in terms of fluid. So I think probably 12 hours is about right, and I'll explain what that means. So, for example, this 14-month-old child had 3 days of vomiting and diarrhea. Presented, as I showed you before, with lethargy and sunken eyes and poor skin turgor and cold limbs, and that the child's weight was 9.2 kilos. And so you can know from this picture the clinical features that the child's at least 10% dehydrated. And so if a child's 10% dehydrated of 9.2 kilos, then they'll be 900 mils down, all right? 10% of 9.2 kilos, that's 9,200 mils, will be, roughly speaking, 900 mils. So their deficit, you know that you've got to replace at least 900 mils in the next 12 hours to catch up with their deficit. So if you replace that over 12 hours, then 900 divided by 12 is 75 mils an hour. Right? That child's maintenance, 9.2 kilos times 100 mils for the first 10 kilos. So it's 920 mils. And if you replace that over 24 hours, remember that's the replacement for a 24-hour period, then their replacement will be 920 divided by 24, which is 38 mils an hour. That's the maintenance. The deficit was 75, the maintenance was 38. And this child had had 4 diarrheal stools in the last 12 hours. So that's, remember, under 2 years of age, it's 50 mils per diarrheal stool. So 50 times 4 is 200 mils, and you divide that by 12 hours, that was over a 12-hour period, so an extra 17 mils an hour. So at least this child would have to have 75 as the deficit, plus the maintenance, 38, plus ongoing losses, 17, and that's 130 mils for 12 hours. And now the reason I go through all of this is because sometimes you might think that 130 mils is a lot of fluid for a child who's only 9 kilos. But when you calculate it out, that's exactly what this child needs to replace their deficit over a 12-hour period. And I would always come back and look at the child after a few hours and see if, one, they've got more diarrhea or they've got more vomiting, in which case you might need to increase the amount of fluid that you give them, and definitely come back at 6 hours and 12 hours and see if the child's showing signs of rehydration. The reason you have to reassess is because all of these are estimates. They're estimates of what the deficit is, estimates of what the child's maintenance fluid is, and estimates of whether or not the diarrhea will settle down or it will get worse after the child comes in. And I think it's good to do the calculation to work out how much fluid the child needs and then reassess things on a regular basis. Right. Mostly for moderate and severe dehydration, then enteral rehydration is much better. And as you know, oral rehydration solution is a wonderful fluid that enables the absorption of water and glucose and sodium, and it does so by having just the right amount of glucose. If our oral rehydration solution has more glucose in it, then that will actually cause diarrhea. But the World Health Organization oral rehydration solution is worked out with exactly the right amount of glucose to optimize the absorption of water and sodium. And that's why if children are given the wrong sort of fluid when they have diarrhea, if they're given, for example, lemonade or fizzy drinks or something like that, then that has too much sugar in it. And that will often cause an osmotic diarrhea where they're losing more water because that glucose can't be absorbed. So the great thing about oral rehydration solution is that it's been worked out with exactly the right amount of glucose and sodium, so that that can be optimally absorbed through the small intestinal mucosa. If possible, you should continue to feed children during serious illness and if they're dehydrated. So I always continue milk feeds if you can, and that's because it does maintain the peristalsis of the bowel, and it maintains the mucosal integrity of the bowel. If you stop feeding a child for 48 hours, then the mucosal lining of their bowel becomes atrophied, and that can lead to other problems such as the translocation of bacteria across the bowel and into the bloodstream. So by enterally feeding patients still if they have gastroenteritis, then that can reduce the risk of a secondary bacterial sepsis. It produces some gastric protection because most of the time the stomach is producing gastric acid, but if we can feed children and put some milk into their stomach, then that can neutralize the gastric, the very acidic pH of the stomach. And also it reduces constipation. If you don't feed a patient for a long period of time in hospital, then they'll get constipated, and that's not a good thing. That's different to diarrhea, of course, but this is in general, when you've got patients in your hospital, when you're looking after them, don't forget to start some feeds as early as possible. I was going to talk, usually, as I said, enteral fluid replacement is the best form of fluid replacement. But if children do need intravenous fluids, then I want to go through and explain what are the better intravenous fluids to use. And in the past, in pediatrics, we used to use a lot of this fluid called 0.18% sodium chloride and 4.3% dextrose. That was a very common fluid that was used. That's not used by most countries in the world now. It's a potentially very dangerous fluid in the way that it's been used. There are many children that became very unwell when they received large volumes of such fluid if they had serious illness. And so now we don't use that, but we try to use what's called a balanced salt solution, And there are various balanced salt solutions. The best one probably is Hartmann's solution, or also called Ringer's lactate. If you don't have Hartmann's solution, then there are a couple of others that you can use. Normal saline with some glucose, of course. Normal saline doesn't have any glucose in it. And another one called half-strength Darrow's solution, which again was used as a rehydration solution for many years and has become a bit less commonly used recently. I think Hartmann's solution is probably the best sort of solution to use. And I'll just explain why. Firstly, the 0.18% sodium chloride solution doesn't have enough sodium in it. It's only got 31 millimoles of sodium. On the other extreme, normal saline's got 154 or 150 in some, 150 millimoles of sodium. And whereas in our body, we have somewhere between 135 and 145 millimoles of sodium. So Hartmann's solution, or Ringer's lactate, is probably the closest to normal physiological balanced salt solutions. Right? The second thing is the in our body, if you give normal saline, the 154 is the same. There is as much sodium as what there is chloride. And if you give a lot of normal saline, you're giving a lot of chloride. And normally our plasma chloride level is around about 95 to 110. But if you give a lot of normal saline, you're giving a lot of chloride, and chloride is very acidic. And so if you've got a child who's got severe dehydration from gastroenteritis and they've got a severe acidosis, then often if you give normal saline, their acidosis won't correct. And so ideally, you'd give a solution of intravenous fluid that contained about the same amount of chloride as what there is in plasma. And Hartmann's solution contains that. Right? Now, the one thing about Hartmann's solution is that there's not in all solutions is there glucose. And it's very important that if you're going to use Hartmann's solution or you're going to use normal saline, then you make sure that there is some glucose added to the solution. There are some Hartmann's solutions and Ringer's lactate that contains glucose, in which case that's the ideal solution to use. And there are some that don't. So you need to check which one you have. And the reason why Hartmann's solution is particularly good is because instead of having a lot of chloride in it, so it has a normal amount of chloride, so it's not very acidic. Instead, it has lactate, and you might think, oh, lactate will cause an acidosis because of a lactic acidosis, but in fact, lactate is converted in the liver to bicarbonate. And before Hartmann's solution was developed, a lot of people tried to add bicarbonate to intravenous fluids. And of course, they realized that bicarbonate then becomes a precipitate in the intravenous fluid. So you can't just add bicarbonate to an intravenous fluid and then give it intravenously. You can give bicarbonate separately to children, but that's different. But what you can do is add lactate, and if the liver's functioning well, then it will convert it to bicarbonate. And so you end up giving a solution that has a normal pH rather than an acidic pH. And that's the special thing that's in Hartmann's solution. This is Alexis Frank Hartmann, who was a biochemist and a pediatrician, and he designed Hartmann's solution in the 1930s, a very long time ago, 90 years ago. He designed Hartmann's solution. And he designed it for the treatment of children who had gastroenteritis. And so I think he's a very smart fellow, because he thought that normal saline was going to cause more acidosis. Some of the other solutions that are given will cause hyponatraemia. And so he designed a balanced salt solution and worked out that if you add lactate, then that will get converted by the liver to bicarbonate, and that will normalize the pH within the body. So we've talked about the type of fluid that you give, and what about what volume of fluid? Now, remember I said that when you, the 150-20 rule is a really good start. So for children who are requiring maintenance, the 150-20 rule is a really good start. But many children, not children with gastroenteritis or dehydration, but children with normal hydration, they don't need as much as the 150-20 rule or the 4-2-1 rule, because if you give that intravenously, that will lead to overhydration. And so, for example, if you give full maintenance fluid to children with meningitis, then a quarter of them will get facial edema, and they will have a higher risk of having cerebral edema. And so we need to avoid overhydration. We can teach people the 4-2-1 rule, but generally speaking, in a child who's not dehydrated, you should start with 2/3 of that, or even half that. In a child with meningitis or pneumonia, I generally start with half the 150-20 rule and make sure they get that half if they need intravenous fluids, and make sure you've corrected their dehydration. But I would normally start with a half of the 150-20 rule and then reassess them as they go on. You should try to understand the total fluid intake a child receives. And that's where the 150-20 rule can be useful, because when you add up the amount of intravenous fluid, nasogastric fluid, oral fluid a child may be receiving, then that typically can come to the full maintenance fluid, the 150-20 rule. But it's surprising how much fluid is in drug flushes and drug diluents, and that may add an extra 25 to 50% even to the total fluid intake a child receives. So we think we're prescribing a certain volume of fluid, and then when we're also prescribing extra, I'll just, sorry, can you mute your microphones here? When we're also prescribing extra medications, we sometimes don't realize that we're actually prescribing a lot more fluid. And so it's important that we think about the TFI, or the total fluid intake the child should receive, right? And it shouldn't be more than the 150-20 rule or the 4-2-1 rule. It shouldn't be more than that, unless of course they're dehydrated. And usually it should be quite a bit less than that. When I said that Hartmann's solution doesn't have, some forms of Hartmann's solution doesn't have glucose in it, you can add glucose to it, and you need to know, have an understanding how to make up intravenous fluids to add glucose to make it 5% glucose. And the way you do that is to dilute it at a ratio of 1:9. So you can add 50 grams of dextrose or 50 grams of glucose to make up 1,000 mils of fluid. And that will give you a 5% solution. 50 grams in 1,000 mils will give you 5%, right? And to make 50 grams of glucose, then if you use 50% dextrose, then the 50 grams will be in 100 mils, right? So you need to add 100 mils of 50% dextrose to up to 1,000, so to 900 mils of Hartmann's solution, and then you'll get Hartmann's solution and 5% glucose, right? So theoretically, you'd need to take out 100 mils from this 1,000 mil bag of Hartmann's solution, and then add 100 mils of 50% glucose to that, and then you've got Hartmann's solution plus 5% dextrose, okay? So 100 mils of 50% dextrose to 900 mils of Hartmann's solution. It's much better though if you've got Hartmann's solution that contains 5% glucose. And so I think when people are ordering fluid, that's what they should be asking for, not Hartmann's solution plain and then add it later. And obviously the reasons why it's better not to add glucose to Hartmann's solution or to normal saline is because of the risk of the introduction of bacteria when you're doing so. But also there are dangers of having 50% glucose solution around your wards, and that is that people might think that they're just like any other intravenous fluid and might actually give them as an intravenous fluid infusion, and that's very dangerous because it's a very hyperosmolar solution, and that can cause very serious problems with marked hyperglycemia and hyperosmolarity. I won't go into it too much, but it's better to have as a stock solution Hartmann's solution plus 5% glucose. I wanted to briefly talk about hypo and hypernatraemia, and the reason being is that they are very common. Both of those, both hyponatraemia and hypernatraemia is very common, especially hyponatraemia in common conditions. So in septicemia or bronchiolitis or pneumonia or meningitis, you can see the proportion of children that have a low serum sodium and the proportion of children that have very low serum sodium, like less than 130, where children are quite likely to get into trouble with hyponatremia. And the problem with hyponatremia is that it lowers the serum osmolarity, and that leads to water being absorbed into cells. All right. Now, just to go back to basic physiology for a moment, you need to understand how to calculate the serum osmolarity. There's several different calculations, but the best one, probably the simplest one anyway, is 2 times the sodium plus glucose divided by 18. So glucose in millimoles per liter divided by 18, plus the urea divided by 1.8. So the osmolarity of your blood is made up of mostly the sodium and somewhat the glucose and a little bit of the urea. All right. And the normal serum osmolarity is 275 to 295 milliosmoles per kilogram. And the reason I go through this now is that if you have severe hypernatremia, a very high serum sodium or a very low serum sodium, that markedly increases or decreases the serum osmolarity because you've got 2 times the sodium. And that leads to major shifts of water in and out of cells. The sodium doesn't travel across the cell membrane, but water will travel to try to correct the serum osmolarity. And so if you've got very low serum osmolarity, very low because you've got low serum sodium, then water will move into cells and the cells will swell. And if you've got a very low serum sodium, then sometimes this can happen. And this is the CT scan of a child who had a rapidly falling serum sodium with hypoosmolarity, and that child developed cerebral edema and seizures. And you can see how swollen this child's brain is. And in fact, there's not just diffuse swelling, but there's coning of the cerebellum through the foramen magnum. So that's a rare occurrence, but it's more likely if a child's got an underlying brain problem, like it's more likely if they've got meningitis, if they drop their serum sodium. So if a child's got a brain injury of any sort, we try to keep the serum sodium above 140 to 145 would be ideal, but certainly don't let it drop below 130. That can be very dangerous. The reason why hyponatremia occurs is because of, I mentioned at the start about antidiuretic hormone. And when you're sick with meningitis or pneumonia or post-operative cases or sepsis, then you are more at risk of having hyponatremia because you've got high levels of antidiuretic hormone that are reabsorbing water, and you're not passing so much in the way of water, and that dilutes the serum sodium. So from a normal serum sodium to one that's very low, and that in some situations can lead to the increased movement of water into cells and cerebral edema. The main implication of this is don't give too much fluid to children who are very sick with meningitis or pneumonia or post-operative or sepsis. Don't give too much IV fluids, and don't give hypotonic fluids. So don't give 0.18% sodium chloride, that solution that I mentioned before that only had 30 millimoles of sodium. If you give that to children that are very sick with meningitis or pneumonia, then they're much more likely to get cerebral edema. Whereas if you give a smaller amount of Hartmann's solution, that's the safest way to do it. Okay. The other extreme is hypernatremia, and that occurs when children are losing more water then they're losing salt. And so sometimes with gastroenteritis, we lose water and salt at about the same amount. But sometimes there's an osmotic diarrhea and we lose more water than we lose salt. And so we might absorb the salt but lose the water. And that can cause the serum sodium to be very high. It sometimes occurs when people try to rehydrate children with the wrong fluid. So remember I said, if you just give children fizzy drinks, even if they're flat, like you've left them out for a while and there's no bubbles in them, that's still got too much glucose in the solution. And if you give that to a child, or another one that sometimes is used called Polyjewel, or a hyperosmotic solution that's got lots of glucose in it, then that will cause the loss of water, and that will lead to hypernatraemic dehydration. There's a few other conditions that can lead to hypernatraemic dehydration as well. And sometimes children get it because they're ingesting more salt than they are water. And so if somebody tries to make up oral rehydration solution and puts more salt in it, obviously that just leads to salt poisoning and leads to hypernatremic dehydration. So there's probably the most common reason is when children, very young infants, neonates with diarrhea, are breastfed by mothers who are dehydrated, and because what usually happens then is the milk contains a lot of sodium and not so much water. So if there's diarrhea in the family, then sometimes breastfeeding of a neonate can lead to hypernatremia. That's quite common in some parts of Asia. So just be aware of it, I suppose. The features of hypernatremic dehydration, you can usually diagnose it clinically, and that is the skin feels very doughy. It's very, it's like if you try to make bread and you make a bread dough, then the skin feels like that. It's very soft and doughy. And the child will have a very parched tongue, like a very, very dry mucous membranes, but they will often have almost near normal blood pressure. And that's the thing about hypernatremic dehydration, is that all the water gets retained within the intravascular compartment and is lost from the interstitial tissues. And that's why the skin feels very doughy and the mucous membranes feel very dry. This baby had a serum sodium 175, and you can see how sunken the fontanelle is. And that's because if you've got a very high serum sodium, then all the cells, then the osmolarity will be high, and so all the cells will be very dehydrated because water moves out of the cells into the interstitial fluid and into the intravascular fluid to maintain the intravascular volume and to try to correct the hyperosmolarity. And so you can see just how sunken this child's fontanelle is, and you can see that there looks like some ridges there where the coronal suture is. And that's because the child's brain is very shrunken and the sutures then overlap, right? And so hypernatremic dehydration, like this baby's got, presents often with neurological features, and very often such children are mistaken for having meningitis. So if you see a child who's got diarrhea or vomiting and irritability, then think whether they could have hypernatremic dehydration, because sometimes they'll have all the features of meningitis. They'll be lethargic, they'll be irritable. They sometimes have even neurological signs like hyperreflexia, or they have seizures because of the cerebral dehydration, and they'll have a reduced Glasgow Coma score. They'll be quite poorly conscious, and often a very sunken fontanelle if they've got a patent fontanelle. This is the MRI scan actually of a child with severe hypernatremic dehydration, and you can see that there is a shrinkage of brain cells and sometimes hematoma formation and bleeding that occurs in the brain in children who've got severe hypernatremic dehydration with neurological features. Now, most children with hypernatremic dehydration don't have such severe neurological features, but the clue in managing such patients is to correct their dehydration more slowly. And of course, if they've got shock, you need to correct it more quickly. But if they're just got hypernatraemic dehydration with moderate or severe dehydration, then typically correct over 48 to 72 hours. And you try to get the sodium to fall slowly. So depending on how high it's been and how long it's been high, then the sodium should not fall faster than 0.5 millimole per litre per hour. So about 12 millimoles per 24 hours. So the child who had a serum sodium of 175, in 24 hours time, you'd be happy if that serum sodium was 163, because that would be 12 millimoles over a 24-hour period. You wouldn't want the serum sodium to fall in this child any quicker than to 163 after 24 hours, and then another 12 millimoles over the next 24 hours. So my point being that you correct it rather slowly. In such children, I would always try to give Hartmann's solution with glucose if you can, but if not, then you can give normal saline. That's got 154 millimoles of sodium. And if you're starting with a serum sodium that's above 150, then it will normalize to that same level, to 150. But if you're using Hartmann's solution, it might drop a little bit quicker, and therefore you've got to monitor it on a regular basis. That's all. When we're monitoring children who are on intravenous fluids, then we need to check for certain things every day. And we should check for signs of dehydration and signs of overhydration. So I always check children for edema. So check if they got puffy eyes or limb swelling. Sometimes that occurs around the hands and the feet, but usually the eyes become puffy first. If a child's got starting to get puffy eyes, then reconsider the intravenous fluid and decide whether or not they still need to have IV fluids or whether or not you can slow it down. Check them for signs of dehydration every day. So check their capillary refill, check whether they've got warm or cold limbs, check to see if they've got sunken eyes or poor skin turgor, if they're tachycardic or hypotensive, or if they've got a low pulse pressure. It only takes 30 seconds to check all of those things. And so every child on IV fluids, you should check that every day. And ideally, every day, if a child's on more than 50% of maintenance fluids with IV fluids, you should weigh them every day, because an increase in their weight usually means that they're getting fluid overloaded. So, and if the child gains too much weight, then you should stop their IV fluids, or you should check this, and you should check their serum sodium. So if they're getting puffy eyes, or they're gaining weight too much, then reassess the need for IV fluid. And ideally, you should check their electrolytes daily or every second day if they're on a substantial amount of IV fluids. That's why it's good to give Hartmann's solution, because you don't need to check quite as much, because usually if you give the right volume of fluid, then the serum sodium won't go too low and it won't go too high. So before we had balanced salt solutions and all we had was 1/5 normal saline, that very low sodium content solution, we would need to check the serum sodium very regularly. But it's just a good thing to use a balanced salt solution when you're giving intravenous fluids, so that you don't need to check the electrolytes quite so much. I was just at the end, I was just going to make a comment about fluid boluses in children with shock. Maybe we can talk about this on another occasion. We'll talk about shock on another occasion, I think. But we'll finish up, I think, shortly. But just in terms of what we talked about today, we've talked about children with dehydration and how to calculate the rehydration fluid, and it's based on the maintenance, the deficit, and then adding some more for ongoing losses. We've said that it's good to use an isotonic fluid or a balanced salt solution. They're the same, isotonic or balanced salt solution, because that minimizes the risk of hyponatraemia and minimizes the risk of getting hypernatraemia as well. We should, in all our patients, avoid overhydration. We should try to keep them what we call euvolemic, right? Not too overhydrated, not underhydrated. So we should teach the 4-2-1 rule or 150-20 rule, but usually start with 2/3 of that, and sometimes start with half of that, and then continue to reassess them. We should know the TFI, the total fluid intake, of patients on intravenous fluids. And remember that when whatever drugs you prescribe, that might come with extra fluid. The diluent for the drug adds to the amount of fluid a child receives. If you give any blood products, that adds to the amount of fluid a child receives. And so you should know the TFI, the total fluid intake in any child on intravenous fluids. I won't talk too much about fluid boluses today, but except to say that we shouldn't give large IV fluid boluses to children if they're unless they're in shock. All right. If you're going to give a bolus, then a bolus of 10 mils per kilo is okay, and then to reassess the patient. And in any child who still has signs of shock after 20 or 40 mils per kilo of fluid, they should have a review by someone from the intensive care unit. And usually, because you need to decide what else they need besides just more and more fluid. That's different if they've got dehydration, but in children who have shock from sepsis, then we know that large boluses of fluid can be dangerous. And I think we should ask ourselves each day about every patient, does this child still need their IV today, or can we take it out? Can we change to enteral nutrition? And are we giving this child enough nutrition? So when we think about fluid and electrolyte management in children, I've just gone over the basic physiology of fluid and electrolyte management, how to calculate rehydration fluid, and said something about the complications, hypernatraemia and hyponatraemia. But I hope that helps us all be safer and better at managing fluid electrolytes in the patients we look after. So I'm going to stop there and see if anyone's got any questions. I think most of these principles that I've talked about today are well known to people, but it's just important that we do teach them and we don't prescribe intravenous fluids poorly or allow intravenous fluids to be prescribed poorly, because they do contribute a lot to morbidity and mortality in our hospitals if we do it badly. So if we stick to these basic principles, I think we can do it safely. But I'm happy to answer any questions or hear any experiences that people have.